بسم الله الرحمن الرحيم. It's a pleasure to start the liver and HCC session. I'm glad to have Dr. Mohammed Shawqi and Dr. Imam Barakat as co-hosts for this session. First, I would like to introduce the first speaker, Dr. Ali Saeed from Al Salam Center. Dr. Ali is one of the eminent and most dedicated and talented interventional radiologists I've ever known. الحقيقة دكتور علي يعني من الناس اللي يعني علما وخلقا ويعني شطارة وكل حاجة يعني. دكتور علي اتفضل. He will talk about neoadjuvantase prior to curative HCC surgery.
السلام عليكم. شرف ليا طبعا النهارده اكون متواجد واشكر الدكتور محمد استاذي على kind introduction. Neoadjuvantase before curative HCC surgery. Hepatocellular carcinoma is a common malignant tumor occur worldwide, and Egypt is a hotspot for this disease. With hepatitis C virus infection is a major risk. 65% of patients have multicentric disease, and 35% affects both lobes. Among cancers, HCC have a high rank in morbidity and mortality rates. Or most of us take the Barcelona Clinic Liver Disease classification as a guideline for HCC treatment, and it categorizes HCC into very early stage and the early stage A, intermediate stage B, advanced stage C, and the terminal stage D. The current modification have improvement in the overall survival according or as regard the very early stage and early stage, and have dedicated stratification of the advanced stage, stage C, as regard the systemic treatment. The neoadjuvant therapies is the administration of therapeutic agent prior to definitive surgery to correct or to solve a few problems. One of these problems that the surgery leaves a small future liver reserve, and the neoadjuvant therapy is desired or is required to improve the function or improve this insufficient residual liver volume. Another problem that the large tumors in a specific location tend to invade or disseminate into portal or bile ducts, and neoadjuvant therapies helps to decrease or make the invasion slower. Another problem or another benefit of the neoadjuvant therapies in general, and this point is specific for the drug neoadjuvant therapies, improve the sensitivity of the drug to the HCC after surgery or with RF ablation, which is called abscopal effect, which enhances the immune system to the neoadjuvant drug. Another problem, neoadjuvant therapies might be an option to reduce the risk of early recurrence, especially with the newly administered immunotherapy. Several types of neoadjuvant therapies, which one of them transarterial chemoembolization, which is the topic of our lecture, transarterial radioembolization, systemic therapies, and antiviral treatments. Overview of the taste of our topic today, transarterial chemoembolization. It's a procedure combining the occlusion of the arterial supply of the tumor and condensation or administration of chemotherapeutic material in the tumor along with the embolizing agent, which may be cisplatin, may be doxorubicin or another drug. And the injection is made till disappearance of the tumoral blush with just care of the puncture site and control of the post-operative post-embolization syndrome, which is a symptomatic treatment. This is the picture of the mixture being prepared and followed by gel foam injection to completely occlude the tumoral blood supply. This is one of our cases showing here the celiac trunk angiogram and followed by selection and or a specific angiogram of the hepatic vasculature showing left and right hepatic arteries. As we see, a small tumoral blush by selection of the specific tumoral arterial blood supply, followed by injection of the chemolipidol material, showing no arterial blush in the artery or the tumoral bed. And here we can notice that the tumoral margin is larger than the blush that is seen in the angiogram. This is that means that control of the microsatellites or the actual margin of the activity of the tumoral activity had been done. Another case with the celiac trunk showing left hepatic artery arising only from the celiac trunk, and there is a blush, large tumoral blush in front of the spine, and when injecting the chemolipidol material, complete cessation of the blush with no tumoral activity. Another case with classic anatomy showing right and left hepatic artery arising from the celiac trunk with the right hepatic lobe tumoral blush at the lower segments and the control films showing no tumoral activity. Another case with large tumoral blush in the right hepatic lobe and the control of the control films showed no tumoral activity, and the CT films post-operative showed condensation of the chemolipidol material. Complication of TACE is the most common complication in the post-embolization syndrome in the form of abdominal pain, vomiting, and low-grade fever and nausea. However, the most feared complication is liver failure after embolization, and this could be avoided by selection of cases and avoid child C classification patient, as this may early deteriorate the patient into inevitable complication. Another complication specific to the neoadjuvant treatment or neoadjuvant clinical scenario. If we had surgery after transarterial chemoembolization, most surgeons may encounter, as this systemic review showed, that few papers stated that more perihepatic adhesions and longer operation time was noticed at the TACE group. In another systemic review, studied many studies. However, 18 studies that was eligible. 3 of them only was class 1 evidence. However, the rest was class 2 and 3. This systemic review showed that the overall survival had improved in few of cases. However, the disease-free survival was not stated in every case. However, this study showed that the effective TACE, meant by effective TACE, that good control of the tumoral blush stated by 57% improvement in the disease-free survival compared to ineffective TACE. Also, the multiple times to do TACE to control the tumoral activity showed increase in the disease-free survival compared to one time or no TACE at all. The same paper stated that the complete pathological response in the form of capsular invasion and capsular protrusion was noticed with the more sessions of TACE to be done. Another study showed that the overall survival and the disease-free survival improved with the TACE group after hepatectomy. Another study stated that TACE with portal vein embolization gives more overall survival and the disease-free survival in the same group compared to portal vein embolization only to increase the future liver reserve after hepatectomy. TACE and portal vein embolization increase the rate of hypertrophy more than portal vein embolization alone. As regard the TACE, occlude the arterial blood supply, which may hypertrophy after portal vein embolization. This is decrease the risk of rapid tumoral progression before the hepatic resection. Again, we back to BCLC, and here we should see that stage A and stage early stage, very early stage 0, treated by ablation and transplantation. Transplantation is the choice for unresectable hepatocellular carcinoma. However, patient will not go surgery to resect the tumor. They may gain benefit from liver transplantation. And by neoadjuvant TACE, we can decrease the waiting list dropout before liver transplantation, reducing the HCC recurrence and bridging treatment by moving the patient or the lesion from outside the Milan criteria to inside the Milan criteria to be eligible for transplant. This meta-analysis showed that the survival after liver transplantation for patient doing TACE is reaching 94% at 5 years, and some papers stated 100% at 4 years. With the TACE for bridging for liver transplantation, the overall survival is much improved when with no progression of the activity after TACE session, as well as cancer recurrence has been improved after doing TACE as a bridging for liver transplantation. And the overall survival is much more increased when the necrosis is over 80%. Another meta-analysis showing that the recurrence-free survival after TACE in some papers reaching 68% at 5 years. Take-home message, the role of neoadjuvant therapies in the management of HCC is currently less well-defined. However, the rationale is preoperatively for TACE as a neoadjuvant treatment is to prevent the recurrence, and it improves the resectability of unresectable HCC downstaging and give a chance for liver transplantation. However, we need more research to be existed to stratify the guidelines. Thank you.
Thank you, Professor, for your elegant talk. بس أنا في الحقيقة ليا two comments و one question. First comment إن حضرتك قلت new adjuvant therapy that's يعني two goals. One to improve the liver functions and the other to overcome the problem of microsatellites and something like that. هو كيمو عشان يimprove the liver functions لا في الحقيقة مش هيحصل. يعني أنا as a hepatologist يعني نيفر ان انا هعمل كيمو عشان تو امبروف ذا ليفر فانكشن. بالعكس انا مشكلتي ان احنا نعمل نيو ادجمنت او ان انا ادي نيو ادجمنت بيفور سيرجري، ان ساعتها البيشنت لو الفانكشن بتاعتها ماسكه بتاعته ماسكه نفسها ممكن الكلام ده يتغير خالص بعد الكيمو. الحاجه الثانيه في البيشنت سelection فور كيمو، حضرتك قلت احنا تشايلد سي مش بنسلكت. الحقيقه لا تشايلد سي ولا ليت بي. يعني احنا لو انا هسلكت الايرلي بي يعني بي 7 وحتى للسيرجري، يعني البيشنت لا هيبقى لا امينبل فور كيمو ولا هيبقى فور سيرجري. يعني حتى بي 7 ده بيبقى عليه يعني بيج كويشن مارك، والبيشنت شود بي سيلكتد ويبقى مالتي ديسيبلينري. السؤال بقى your own experience with portal vein embolization to make hypertrophy to the liver. Your own experience ايه؟
انا متفق مع حضرتك تماما. كومنت الاول على التو بوينتس. هو انا متفق مع حضرتك تماما. احنا قلنا الجول بتاع النيو ادجفانت ثيرابي تو بريفنت ريكارنس وتو امبروف السرفايفل والليفر فانكشن زي ما حضرتك قلتي تماما. الكيمو we should select the patient as the chemo embolization is a chemotherapy to the liver will inevitably disrupt the liver function. كتشايلد سي طبعا child C is not an option for TACE or surgery because it is stage C, stage D, terminal stage. It is for best supportive care. However, I'm just quoting the research. As regard the portal vein embolization, portal vein embolization يعتبر بوجهة نظر الجراح the best option for hypertrophying the future liver reserve. طبعا المنافس القوي ليه والefficient فعلا، ولكنه very many complication as regard post operative complication and decompensation اللي هو الألبس association liver partition and portal vein ligation for staged hepatectomy. Very disastrous operation. Portal vein embolization safe and صحيح ما بيحصلش الفاست جرو زي الألبس، ولكن الألبس بيحصل فاست جرو للليفر تيشو لا يقابله جرو للفانكشن of the liver. The volume of the future liver reserve is very fast and more than any other hypertrophying preoperative operation in ALPS. However, very many complications in ALPS. The function is not guaranteed in many cases. Portal vein embolization alone give hypertrophy adequate. However, it is slowly than ALPS. With less complication than ALPS.
في الحقيقة يعني أنا as a hepatologist بكويشن البروسيس دي، لأن الليفر اوريدي سيروتيك. الهايبرتروفي أو الإكسبكتد هايبرتروفي في سيروتيك ليفر مش هيبقى مثلا لو نورمال ليفر أو يعني نون ديزيز ليفر. يعني مثلا احنا عندنا هنا المين etiology of liver disease hepatitis C. So the patient to develop HCC mostly بيبقى سيروتيك غير الهيباتيتس بي مثلا. يعني الاكسبيرينس بتاعت الناس الهيباتيتس بي اتيولوجي وفي HCC ممكن يعمل الهايبرتروفي ويكسبكت بيتر ريزلتس. لكن احنا بالنسبه لنا في الحقيقه برضو في عيانينا احنا الايجيبشن بيشنتس، عشان كده يعني سالت حضرتك على يور اون اكسبيرينس كويشنبل في الحقيقه.
بس البورتال فين امبوليزيشن دكتور ايمان، انا بس يعني احب من فوائده غير ان احنا تشوف نكبر الليفت لوب، ده بيتست ريجنريتيف فانكشن. فانا بعمل بورتال فين امبوليزيشن وما يكبرش الليفر بالشكل ده، فكويس، لا مش هيجرى له حاجه، مش بالعكس ده قالوا ده افيشنت. المشكله ده لو عمل جراحه كان هيتنيل اكتر يعني، فده كويس الحمد لله احنا عملناه. ده بيتست الجنريتيف فانكشن ان لو عمل جراحه فمش هيستحمل. شكرا دكتور علي.
طب ممكن بس سؤالين صغيرين كده بتاعي لو تكرمت. انا بس على السؤال وات ذا effects of injection of radioactive materials على normal liver cells. injection of radioactive materials radiotherapy focal lesion of the liver.
راديو امبولايزيشن. تمام. طبعا الراديو امبولايزيشن من الحاجات اللي لو احنا بنتكلم في السيتنج بتاعنا اللي هي النيو ادجفنت ثيرابي، طبعا كتشايلد بي او سي تير او راديو امبولايزيشن is not preferred. We should select the patient eligible to radio embolization لأن radiation hepatitis برضو is a common complication. Also we are doing pre-operative session testing session to test the hepatopulmonary shunts to prevent occurrence of radiation pneumonitis. But in the setting of neoadjuvant clinical scenario of radio embolization, الراديشن لوبكتومي كمان الراديشن لوبكتومي بيعمل هايبرتروفي للكونترالاترال ليفر للكونترالاترال لوب زي البورتال فين امبولايزيشن بالظبط، واخد بال حضرتك؟ يبقى هي ممكن تبقى ثيرابيوتيك للليجن، وكمان ناخد الكيوراتيف ريزلتس باي سيرجري افتر راديو امبولايزيشن. نو يعني التوكسيك سيمبتومز اوف راديو امبولايزيشن is much less than chemo embolization and drug eluting beads. However, child A is a mandatory to perform radio embolization.
معلش السؤال الثاني وشكرا طبعا. عايز افهم بس الرول اوف نيو ادجوفنتيز in preparation او for preparation of liver transplantation. يعني برضو ما احنا liver transplantation الليفر كله بيتشال يعني. what is the rule of test in preparation for liver transplantation؟
هو زي ما قلنا كده هم حاجتين most commonly used. احنا طبعا عايزين نقلل الريكارنس وعايزين نبرولونج السرفايفل. هو الجول بتاعنا في الاخر السرفايفل، والسرفايفل بيبقى امبروفد لما كل ما قربنا للكرايتيريا اللي هي ميلان كرايتيريا. في عيانين ممكن ما يبقوش وذين الميلان كرايتيريا فبنعمل لهم داون ستيجنج. ليجن فوق ال 8 سم ممكن نعمل له تيس يديكريز او الاريا enhanced in the cross sectional imaging which بتعبر عن الاكتيفيتي او اللايف تيومر much decreased. Then it is will go within Milan. هيبقى يطبق within Milan criteria، يطبق عليه الكرايتيريا بتاعت الليفر ترانسبلانتيشن or bridging. البيشنت is في رحله الترانسبلانتيشن عنده يعني تحضير طويل جدا 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 may be dropped out or the lesion may progress. The TACE will control the tumoral activity, will limit the growth, will prolong the progression-free survival till the patient obtain curative results from liver transplantation.
Thank you.
شكرا.
Thanks, Dr. Ali. Here introduce my dear Professor Dr. Osama Dali, the head of Medical Oncology Department at Dumyat Oncology Center, and his session about new horizon in managing advanced HCC, systemic service and beyond. تفضل دكتور أسامة.
Bismillahirrahmanirrahim. Thank you, Mr. Chairman, for this nice introduction. My congratulations for this successful conference. Many thanks, Dr. Ali, for invitation, your kind invitation to be here with you and to discuss the new horizon in managing advanced HCC, systemic therapies, and beyond. The cancer registry in the Dumyat Cancer Center, we have the instance of HCC. It's ranking number 1 in both sex, male and female, and also ranking number 1 in male patient, while ranking number 2 after breast cancer in female patient. what is about the incidence and mortality in Egypt. The incidence and mortality of liver cancer in Egypt is about more than 3.5 times that of the world. And however, the mortality of liver cancer worldwide and Egypt is very high, showing a less curative type of cancer. And we need for sure more effort to prevent this, and prevention for sure by screening. And screening is the hope for early detection and eligibility of treatment and improved survival. The screening should be every 4 months with alpha-fetoprotein and abdominal sonar in high-risk patient, which is either cirrhotic in hepatitis B, hepatitis C, NASH, alcoholic or hematocomatose, and non-cirrhotic with hepatitis B carriers. The overall survival in HCC should be influenced by child classification. Patient with child A is more benefit from treatment, while child B and C for sure has this survival in our curve. The only curative option for early stage HCC is liver transplant with overall survival about 10 years. And if we go for resection or ablation, we talk about 6 years of survival. But we note that TACE or systemic therapy, we talk about palliative treatment and not curative treatment at all. And if we have a patient with terminal stage C, we go for best supportive care. There are many challenges in HCC treatment. It is a common malignancy with complex malignancy heterogeneous etiologies, complex molecular carcinogenesis, and we have one patient with 2 diseases, cirrhosis and HCC. Our patient may be present with portal hypertension, thrombocytopenia, impaired hepatic function. Although transplant is potentially curative, but the access is limited in our country to this moment. So we need a multidisciplinary approach to treat with this patient. The multidisciplinary approach will improve the outcome in the form of survival benefit, more prescription, and more early detection for our patient. The story starts in our colleagues in Mansoura University by a drug called at this moment the Viscum. And we have 2 phase 2 trials, and the net result of the 2 trials that further randomized controlled trials are recommended, but unfortunately this drug was disappeared from our market. We talk about this recent data on frontline to treatment advanced HCC, and when we talk about advanced HCC, we talk about intermediate stage B, when the patient presented with diffuse, infiltrative, extensive bilobar liver involvement, and advanced stage C with the portal invasion or extrahepatic spread, but with preserved liver function and performance status should be 1 or 2. If the patient is terminal, we go for best supportive care only. The chemotherapy is not used nowadays because multiple factors. It's less effective. Patient cannot compliance the chemotherapy because for BS, performance status, ascites, portal vein thrombosis, impaired liver function, and thus chemotherapy was removed from our guidelines, either MCN or ESMO guidelines. However, still we can use chemotherapy in the 3rd or 4th line of treatment after failure if the patient have good BS and good liver function. The story started with sorafenib at 2007 with overall response rate about 2% and overall survival 10 months. The story progressed when we use atezolizumab, overall response rate about 30% and overall survival reach about 19 months. This is the drug for first line Lenva, atezolizumab, durvalumab, tremi, and second line regorafenib, nivo, pembro, cabozanib, ramucirib, and combination of nivo-ipi. We should evaluate our patient, check the classification for cirrhosis, and we should go for upper GI endoscope before starting treatment to search for viruses. And when we talk about atezolizumab versus sorafenib, we have an advantage of overall survival about 19 months, overall response rate 30% versus sorafenib 11% only, and median duration of response about 18 months versus only 15 months in sorafenib. The side effect of GI bleeding reach about 7% in atezolizumab, while in sorafenib arm about 4.5% only. So to be careful when you use atezolizumab. This is contraindicated with atezo with history of organ transplant, history of autoimmune disease, and please take care of itis, pneumonitis, hepatitis, colitis, and so on. And when we use Biva, it's contraindicated in GI perforation surgery in last 28 days, recent hemoptysis, fistula, uncontrolled hypertension, proteinuria, and congestive heart failure. What about immunotherapy? The Nivo, it doesn't affect any significant overall survival, and we recommend the use of Nivo if there is contraindication to sorafenib and patient in child B7. Child B7 we can give either Nivo or sorafenib only. In the Himalaya trial, the value plus Tremi, we achieve an median overall survival about 16 months, and the overall response rate 20% versus only 5% in sorafenib arm. The story for sure started with the SHARP and Asia Pacific trials and gave the sorafenib to be standard of care in 2007 by inducing overall survival benefit. The REFLECT trial shows that lenvatinib is not inferior to sorafenib. So we can summarize the first line treatment. If you have to go for combination, go for atezolizumab or durvalumab. If you can go for one drug, you can go for lenvatinib, sorafenib, and Nivo. Please, all drugs should be patient child A, except patient in child B7. We can use sorafenib or Nivo. What is the optimal sequence if the patient is progressed in the first line and we need the second line? According to randomized controlled trials, we have 3 drugs in the second line: regorafenib, cabozantinib, and ramucirumab, while other drugs can be used till the result of randomized controlled trials. So if the patient is progressed, we can use regorafenib, but the patient should be sorafenib tolerating patient only, and we give ramucirumab if the alpha fetoprotein equal or more than 400, and we can use cabozantinib also. We notice that the overall survival in 3 drugs is about 10 months only. If we use Nivo plus Ebi in the second line, we reach an overall survival about 22 months. If we use Pembro, we reach about 14 months. Now the question is there a systemic therapy combination for early and intermediate stage for HCC? Early and the intermediate HCC, for sure. As go early, we use local regional therapy. As go late in HCC, we use a systemic therapy with some exceptions. So this is a trial of using sorafenib plus TACE in the early stage, and there is no any significant either overall survival or progression-free survival, and it is not recommended at all in early stage. And this is an ongoing trial to show that if there is a benefit of TACE by plus combination target therapy or not, and we are waiting the results. This is a trial by using lenvatinib plus TACE. In frontline treatment for advanced HCC, we have median overall survival about 18 months, median progression-free survival about 10 months, and overall response rate doubled the lenvatinib only. But the expense here is the grade 3 and 4 adverse event. In systemic therapy for patients with larger intermediate stage, for sure we can use systemic chemotherapy, systemic lenvatinib with median overall survival and progression-free survival benefit more beneficial, and overall response rate about 73% versus only 33% in the arm of TACE. The TACE is unusually to be repeated. We show that please stop TACE when we have 2 consecutive ineffective or progression upon TACE, and when the tumor marker increase or there is a vascular invasion or extrahepatic spread. What about the adjuvant following resection or ablation? We have a new trial in BRAVE 015. This is the design of the trial with one arm of atezolizumab for 1 year after resection or ablation, and this is the result. With recurrence-free survival was significantly improved with atezolizumab versus active surveillance, and also the disease recurrence was about 33% lower in atezolizumab arm. But unfortunately, there is no any survival benefit, and our patient allowed to cross over to receive atezolizumab in the arm, and from this, about 61% of patient was crossed over to atezolizumab, and this is the conclusion of the authors, that atezolizumab may be a frontline after this as adjuvant, like in breast cancer and colon cancer, but still nowadays it's not approved yet. And so, in our recommendation in neoadjuvant and adjuvant therapy in early stage HCC, systemic therapy is not currently recommended outside the metastatic disease or disease that is not amenable to local regional treatment. So we can conclude that HCC is an aggressive tumor often occurring in the setting of chronic liver disease and cirrhosis. Treatment options are influenced by child classification, indication for systemic treatment, patients with advanced unresectable HCC who are unsuitable for local regional therapy and have adequate performance status and good liver function. Atezolizumab, Lenva, regorafenib, cabozantinib, and pembro to those with no worse than child classification A. Child B7 can go for sorafenib or nivo. We have made a tremendous progress in improving the survival of patients with advanced HCC. In the near future, we await the result of another frontline studies to establish additional option for patients, including TKI plus immuno or immuno plus immuno combinations. We have a longer term questions. Will these regimens improve outcome in early stage of liver cancer? We can use adjuvant chemotherapy or immunotherapy in this setting. Can we identify predictive marker for benefit between the two regimens? What will be the next frontline regimen? How will we beat a median overall survival just 19 months with atezolizumab? What is the best treatment after progression on first line immunotherapy? And thank you for your attention.
Thank you, Professor, for this elegant talk. الحقيقة أنا سعيدة جدا إن أنت جبت سيرة الفيسكافراكسيني. إحنا من أكتر الناس اللي استخدموه برضه ونشرنا عنه، كان very safe وبيimprove الليفر فانكشن، بس اختفى زي ما حضرتك قلت. Regarding the new era, would you prefer some or one drug over another in cases of portal vein thrombosis؟ خصوصا ان في بعض الستاديز زي الهيمالايا ستادي excluding البيشنت with portal vein thrombosis from the start، although ان هو systemic therapy وان هو في late stage، لكن ما فيش experience. دي اول حاجه. الحاجه الثانيه، would you prefer برضو one over another according to the etiology, hepatitis C or hepatitis B؟
بالنسبه للفيرست according to first question, I think we in this nowadays, according to guidelines, we stick to atezolizumab first line. Atezolizumab has a more survival benefit, and some of the patients in the trial have portal vein thrombosis. And I have in my clinic only one patient have curative intent CR after atezolizumab, and now he is under follow-up only.
طب لو if your patient was primed with sorafenib وده كان الحال في عدد كبير من البيشنت وبروجرست على السورافenib, would you like to try atezolizumab?
According to randomized controlled trials, there is no standard
Yes.
of care.
But according
to our knowledge, yes, you
yes,
can go for
you can.
immunotherapy,
Okay.
for sure.
Thank you.
Thank you.
Thank you. Okay. Now we are shifting to the talk titled The Evolving Role of RT for HCC and Pancreatic Cancer by Professor Ali Hosni.
Thanks very much for Dr. Ian and the organizing committee for this kind invitation. It's a pleasure to be here. And I'm going to speak about the role of radiation treatment for pancreatic cancer and HCC. Here's my disclosure. So my outline today will be about the SPRT for hepatocellular carcinoma and towards personalized radiation treatment for pancreatic cancer, along with some few guesses to the near future. HCC accounts probably to 80 to 90% of liver cancer. It's the 5th most common cancer worldwide and the 3rd most common cause of global cancer-related death. And the management approach depends mainly on the staging of the cancer. And we don't usually use the TNM staging, we use the BCLC as previously described. And I will go through each one of them and describe how radiation treatment could be of benefit. So for BCLC-A, which likely represent a single lesion less than 5 centimeter or 3, each one less than 3 centimeter, the treatment intent is curative, likely with liver transplant. The local control is up to 90%, and the survival is around 70%. But the biggest challenge everywhere is the long waiting time. And what's happened that if you have a long waiting time, then you have a rate of dropout. So the patient after a while will not be eligible for going with transplant. This is data from my institution in Toronto, and the dropout is probably more than 20%. So how do we come with that? And that's the idea of getting the neoadjuvant, or what's called the bridge transplant, trying to give some sort of local management to delay the progression of the cancer, so we can go with the transplant after 1 year or 9 months, whatever it is. Again, this is data from our institution that patient received either SPRT, radiation treatment, TACE, or RFA. And you can see here the dropout is quite similar, and the overall survival from the transplant or from the initiation of treatment is the same. And most recently, the randomized control trial comparing the proton beam radiation treatment with the TACE showed no significant difference. Actually, even there was a trend to better local control and progression-free survival with proton beam therapy compared to the TACE. Well, and that's a critical point here. So we understand the whole idea of giving this neoadjuvant or bridge transplant, trying to shrink the tumor. And the most characteristic part of shrinking the tumor is obtaining the pathologic complete response, meaning that you do the neoadjuvant therapy, the surgeon will do transplant, then the tumor disappears. In this trial, for patients who received TACE, it was 10%. For patients who received radiation treatment, it was 25%. That's relatively a very good number. And from previous slides, we know that if you obtain a PCR, then the chance of survival at the long term is more. There is a subgroup of patients who are BCLC-A less than 3 centimeters. They can be treated with curative intent with RFA. The local control is around 80%, the survival is 50%, but the challenge here is the medical or technical contraindication. Not every single patient can go with RFA. And there is a study comparing SPRT with RFA. It's like a probability score match, and they found that the local control following SPRT versus RFA is quite similar. Having said that, for lesions between 2 to 3 centimeters, SPRT provide even better local control. And this is known in the literature. If you have an RFA for lesion less than 2 centimeters, the chance of control is very good compared to more than 2 centimeters. Again, this is a practice-changing clinical trial comparing the proton beam radiation treatment with RFA. It's a phase 3 trial. And when they designed the trial, they thought, okay, we're gonna consider the SPRT or the radiation treatment is non-inferior to the RFA. And they put the sample size with the non-inferiority of 15%. So let's say that the RFA will provide a local control of 90%. If the SPRT provide a local control of 75% is acceptable. What happened that the proton beam radiation treatment showed better local control compared to the RFA. But we can't say that radiation is better than RFA because the design of the trial was not like this way. But you see it's around 90% compared to 80%. This trial was published recently and it's changing. I see all the slides come here. It's putting TACE, RFA, transplantation, systemic therapy, but not bringing SPRT. And probably if we have this conference in 2 years from now, you will find the radiation up showing because of these clinical trials. So going to the next stage, BCLC stage B. It's a larger tumor or multifocal. Unfortunately, the treatment intent is palliative, no transplant, no cure. And at that stage, most will probably will go with TACE. The local control is relatively good, 70%. The median survival in the literature between 12 to 18 months, could be less, could be more. But the biggest challenge is the medical or technical contraindication again. Not every single patient will be candidate for TACE. They did a probability score match between patients who received SPRT for TACE, and the 1 year local control was quite similar. And if the patient going to stage C, which means you have vascular invasion, nodal disease, or metastatic disease, the treatment is still palliative, most probably IO and TKI, as just described by Dr. Osama. The local control, the biggest problem with systemic therapy in general is the local control. Is probably 40% with IO combination with TKI was a little bit high, reached to 60%. The median survival in the era of sorafenib, 6 to 12, in the combination up to 20 months. The challenge is the local treatment is not described here because TACE is not available, RFA is not available. And in this case, we probably will thought about what about SPRT? There's a lot of data. There's like accumulation of more than 2,000 patients in 32 studies meta-analysis. They found the local control is more than 80%, and that was maintained at 2 and 3 years. Definitely the survival is diminishing, but the toxicity is not too much. And that actually was evaluated since 2014 by the RTOG 1112. I know this trial very well because I was the highest accrual investigator after the PI, and was published, was actually presented recently in ASTRO 2022, and the manuscript submitted. So simply those patients who are not candidates for TACE or RFA or surgery, they were randomized to receive sorafenib versus sorafenib and SPRT. It's a Brex-changing trial because simply it improved the survival from 12 months to 16 months. Again, this will definitely show up very soon in the newest literature because that's a phase 3 randomized controlled trial and provided an overall survival benefit. And when sorafenib came, it provided a survival benefit of probably a couple of months, and it came very hot off the topic, and everyone was using it. So probably we're going to see that very soon. So that's about HCC. What about pancreatic cancer? So I was just going to make it very fast. So the treatment for pancreatic cancer is mainly, again, not dependent on the stage, very unique issue. It's about the classification of cancer. So some of them are upfront resectable, which means that the tumor is within the pancreas or very limited to the veins like SNV and portal vein. We're definitely going for cure. Standard management is surgery followed by adjuvant therapy, which could be chemotherapy or chemoradiation based, are you European or North American? If European, you usually go with chemo. If you are North American, you usually go with chemoradiation based on the RTUG study and the other trials. The local control is relatively good, 70%, and the median survival is around 24 months. Borderline resectable means that the tumor is a little bit more extensive, more than 180-degree contact with SNV portal vein, and contact with arteries like celiac, SMA, but less than 180-degree. We still can go with curative approach. Ideally, go with chemo radiation followed by surgery, and the local control up to 50 to 70%, and the survival between 12 to 18 months. Honestly, we are seeing this better this number is improving right now with more advanced chemotherapy. And you can go with more disease unresectable, meaning that the tumor has more contact with arteries, more than 180-degree, and definitely is complex palliative, either chemotherapy or chemoradiation, local control between 50 to 70%, but the survival is poor, 6 to 15. Again, with more advanced chemotherapy, we show some improvement here in survival. Patient with metastatic disease, they just go with chemotherapy, unfortunately. So I'm gonna get more focus in the unresectable pancreatic adenocarcinoma. It's a story, and I'm gonna tell you what's happening since 1950s until now, because I like telling stories. The idea was induction versus maintenance sequence here. So first study with the GIT study group, they included 227 patients. They don't know how to start. They did an induction treatment. Should we start with radiation or chemoradiation? They used different regimen, and they maintenance with chemotherapy. So patients start with chemoradiation or radiation, then they continue with chemo. And what happened, they found that if you go with a radiation dose of 40 gray and 20 and get the chemo after, you provide the best outcomes. From that point, they said, okay, maybe we should start with chemo rather than chemoradiation. So the ECHO study came after. It's a Canadian study. They started with chemotherapy 5 FU versus the same regimen which went previously, and the maintenance was the same. And they found in this trial there was no significant difference. So either to start with chemo or chemoradiation, they are the same. then at that point, why don't you do with only single agent of chemo? Let's put multiple agent of chemo, which was the second GIT study group. And they give triple regimen chemo versus chemo radiation, and the maintenance was the same. And they found, interestingly, if you go with chemo radiation, it's better than multiple agent of chemo, and probably that chemo was too much toxic. At that point, by end of 1990s, the French group did the 2001, which is getting a new agent at that time, gemcitabine versus chemo radiation treatment in the induction phase, and the maintenance was the same. The gemcitabine won by far, better overall survival. But it was actually unfair comparison, because you are comparing gemcitabine versus chemo radiation, but you did not use gemcitabine with the radiation treatment. So you are comparing apple to orange here. So that's why the ECHO did another study. Let's compare the gemcitabine versus the chemo radiation using gemcitabine. And at that point, chemo radiation won. Then the French group, because they have a lot of experience with pancreatic cancer, they said, okay, you know what? There is a huge proportion of patients who start with radiation, but they have distant meds. And they published their experience from more than 180 patients from multiple sequential phase 2 trials. And they found around 30% of patients who start even with chemotherapy, they have distant metastases after, because just having hidden disease and showing up with time. And the remaining 70%, based on these trials, either received chemotherapy or chemo radiation. And they showed that if you go with chemo radiation, you have better chance for median progression-free survival and overall survival. And that's actually resulted in the development of the LAB-07 trial, where patients randomized to receive in the induction phase either gemcitabine versus gem with erlotinib. Then those patients who had no progression, they were randomized to receive chemo radiation versus chemotherapy alone. And they found no significant difference, probably a little bit of trend towards improvement of progression-free survival. And you can see here that definitely if you include the radiation treatment in the maintenance phase, you have better local regional control, but you have more chance of distant meds. And these are the lessons that we learned from like half a century. Go with SPRT, short course of radiation treatment, make it very precise and make it personalized. So, and that's what we are doing at our institution back in Toronto. So we tend to think that if you are using a CT-based planning of radiation treatment, you can see the tumor very well, and the MRI has a lot of motion. You see here on the right side, you can see the lesion very well, see the tumor, because we are using a unique sequence of the MRI. It's called T2 high-res average. And not even that, we are giving high dose of radiation, but not only to the whole tumor. We do a FASA-PET MRI where there is an area of hypoxia, and get this hypoxia to very high dose of radiation treatment to provide better local control. Here's some few guesses to the near future, because to make it more exciting even, it's the idea of going with higher dose of radiation to get better control and minimizing the volume of radiation treatment to decrease the toxicity. We're going with MRI only workflow. We don't use any CT now for radiation treatment, which is even more exciting. And when you have the MRI, you can have plenty of functional biomarkers which can define which patient who will benefit versus which one will not benefit, in addition to the radiomics and artificial intelligence. I would like to thank all my colleagues at my institution, and thank you everyone for listening.
Thank you, dear Professor, for your talk. Actually, فعلا radiation is the upcoming. يعني SPRT, upcoming hope for some patients was eligible only for chemo, and this is my question. There is no challenge for us as regarding the small lesions, 2 centimeters, 3 centimeters, RFA almost resolving this problem, and it's curative for the lesion. For patients with larger size, the size between 5 and 6 centimeters, would you prefer to give them SPRT radiation, and would the dose of radiation would change from small lesion to large lesion?
Yeah, that's a good question. Despite at my institution, we are very pro for radiation treatment. But if we see a patient with a lesion of 2 centimeters, we think that it's better to manage this patient with RFA. So I totally agree. And that's because there is a plenty of literature. and probably only one randomized control trial will not solve the problem, but it's coming, no worries. The other part here is about larger lesion. When they started the radiation treatment for SPRT, they had a little bit of fear of what's called the radiation-induced liver disease. In the literature, before 1990, 1980s, guess what? It's up to 60%. So you give the radiation treatment and the patient dies. Then a group of radiation oncologists from everywhere, led by Stanford, defined specific criteria and followed it. They did phase 2, then phase 3 trials, and said it's safe. And nowadays, we are treating patients with a lesion up to 20 centimeters in the RTUG 1112 in a randomized controlled trial. I'm not saying that everyone will be treated this way. Every single patient more than 5 centimeters will go with SPRT. There is no way to give TACE for someone who had a lesion of 7 or 8 centimeters, because we know that the local control for TACE is not good. If the lesion is between 2 to 3 centimeters, we question going with RFA, because we know the SPRT local control is better. And the data from the randomized control trial, if you are bringing a treatment, providing a pathologic complete response of 25% versus 10%, it does not make any sense to continue with the one with 10%. Having said that, I understand there's a lot of resources issues. There's a lot of building experience you need to do. You can't go with first day with a patient at your institution and say, okay, I'm going to treat someone with 20 centimeters. There's no way about that. Then regarding your radiation dose question, we did a meta-analysis among all institutions and we found that the magic number for HCC is BED 10 of 70, which is equivalent to 40 gram 5 fractions. Again, you can whatever think about what you want, but sometimes the tumor is very close to the luminal structures like the stomach, the duodenum, and you can go with that, and you need to lower the dose. Last point, and I said that yesterday, one of my patients received 16 gray single fraction as a bridge transplant, very low dose. And the reason we gave 16 because the liver function was relatively low. And I agree with your first comment in the first session. You are giving neoadjuvant therapy, but the biggest risk that you're going to damage the liver. This could happen with TACE, RFA, or SPRT. So we gave the lowest dose because his liver function was at the just at the edge. 6 months later, this surgery, PCR, with 16 gray. And because we know there's a subgroup of patients with HCC who has a very favorable outcome. We don't know them. We're doing research more right now to know which one is this one, but so far it's working.
Thank you, dear Professor. Any question?
Yes. Thank you, Dr. Ali, for a very interesting, comprehensive lecture. But again, my questions regarding the role of SPRT in tumor from 2 to 3 centimeters. You illustrated some of trials, but most of them are retrospective. So there is no level 1 evidence based until now to use SPRT, although the local control is better than radiofrequency in this size of tumor. So are we able to treat patients like this with SPRT in the absence of prospective randomized trial, or we should go for radiofrequency or TACE?
Yeah, if we're speaking about 2 to 3 centimeters specific,
yes.
I would say we routinely don't go with SPRT unless a discussion with interventional radiologist take place, and we only do SPRT if it is technically not feasible. Let's say the tumor is very close to the biliary tree and he is not able to make it, or close to the diaphragm. Then we'll go with SPRT at that point. I would say, and this is my personal vision, we have a huge number of HCC in Egypt and around areas. Why don't we do a clinical trial like that? It's very simple.
So it should be included in clinical trial, but we cannot go for SPRT instead of radiofrequency.
Definitely not. We'll not do that. Yeah.
Okay.
Only for patients with medical or technical contraindication. And again, why don't we do a clinical trial? Because we already have a lot of evidence. Just do the clinical trial. Simply, and that's again my personal vision. India, like 25 years ago, with all respect to them, they didn't know how to design a clinical trial. They came to North America and Europe, teach us how to do it. They are publishing clinical trials right now, going to ASCO podium, like changing breast clinical trial, because they have a huge volume. So you use this tool, and the cost of conducting clinical trial at their institution is definitely lower compared to North America and Europe. So we have the same privilege here in Egypt. Why don't we do that?
Yes, but in terms of SPRT versus TACE in more larger tumor, for example, 5 centimeter, you go for TACE, starting with TACE, or you
until
can
1
go.
year ago, we were starting with TACE, but now we're changing a little bit because we have data from randomized control trial that you give the choice for the patient, and we tell them definitely we are not competing with our place for interventional radiology. It's a multidisciplinary. We come to a team and take a decision. And now what we are doing, we tell the patient, okay, you have 2 options. There is a problem with SPRT because you come here 5 treatment. I'm not going to start the treatment until 2 weeks from now. It's going back and forth. There is risk for blah, 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 blah. And TACE, you unfortunately have an invasive procedure. The local control is comparable. If you prefer, we are happy to provide both services.
Yes. Yeah. This is my next question. What are your experience about combination treatment? TACE, and would you start with TACE or would you start with SPRT?
That's a great question. And despite I'm a radiation oncologist, I say that with sadness. Definitely start with TACE.
But after failure of 2 TACE, we can go for SPRT. Yes.
Yeah, but the idea here that it's very easy for us, because we are high-tech people, to go with SPRT after the TACE. But you go with SPRT, then the TACE after will be very complicated. And then again, it's not a competition. It's a multidisciplinary for the sake of the patient. And this is very important because we don't treat any liver cancer patient without going to an MCC where the radiologist, pathologist, surgeon, medical oncologist, radiation oncologist, interventional radiologist come all together and take a decision for the patient. So everyone is happy.
Yes, we are doing the same.
Exactly.
But what about the interval between both chemo and SPRT? We are doing both.
The usual approach that we go with TACE, then we don't go with SPRT until we see a progression. Yeah. Usually we do the TACE 3 months after we do a CT, a CAT scan, or MR, whatever it is. If it's responding, keep the patient safe. If there's any progression, then we'll go with radiation. And there is a technical part here because sometimes, and most of the time, the recurrence happening at the edge of the cavity. Yes. So we give the cavity a lower dose of radiation treatment. It's a very non-constant for radiation oncologists called the elective target, and get higher dose of radiation to the area of the recurrence. So even if there is a small microscopic disease left behind the TACE, we can kill it.
Okay. Thank you.
Thank you, Dr. Ali. Let me introduce my friend. Okay, thank you. Dr. Ahmed Safan, Head of Department of Radiology at Tanta Cancer Center. He will talk about the role of interventional radiology in treatment of hepatic mets from neuroendocrine tumor.
It's a pleasure to be here to discuss an important topic in the field of oncology, which is the role of interventional radiology in the treatment of hepatic metastasis from neuroendocrine tumor. Neuroendocrine tumors are a diverse group of neoplasms that originate from neuroendocrine cells. These tumors are characterized by their ability to exhibit neuroendocrine differentiation, which means they possess both features of nerve cells and endocrine cells. Neuroendocrine cells are specialized cells found throughout the body, particularly in organs such as the GIT tract, pancreas, and lung. Neuroendocrine tumor can occur in various organs, but they are most commonly found in the GIT tract, such as the small intestine, appendix, pancreas, and lung. They can be classified as functional or non-functional, based on their ability to produce hormones. Functional neuroendocrine tumors secrete hormones, which can lead to specific clinical syndromes, while non-functional neuroendocrine tumors don't produce significant hormone level. Neuroendocrine tumors encompass a wide spectrum of tumor behavior, ranging from indolent and slowly growing tumor to aggressive and rapidly progressing malignancy. They can vary in terms of their grade, stage, and metastatic potential. Diagnosis of neuroendocrine tumor often involves a combination of clinical evaluation, imaging studies such as CT scans and MRI, and biochemical markers such as chromogranin A and specific hormones. The management of neuroendocrine tumor requires a multidisciplinary approach involving collaboration between oncologists, surgeons, radiologists, and other specialists. Treatment decisions are influenced by factors such as tumor characteristics, presence of metastasis, patient general health, and symptoms. The management approach may involve a combination of local regional therapies, systemic therapies, and supportive care to achieve optimal outcome in terms of tumor control, symptom relief, and improve quality of life for patients. Liver metastasis is a significant aspect of neuroendocrine tumor, as it's a common occurrence and has important implications for patient management. Liver metastasis is a frequent occurrence in neuroendocrine tumor, particularly in those arising from the GIT tract, pancreas, and lung. It is estimated that up to 70% of patients with neuroendocrine tumor will develop liver metastasis at some point during the course of their disease. There is a high propensity for liver involvement is due to the unique anatomy of the portal venous system, which allow tumor cells from the GIT tract to directly reach the liver. Liver metastasis in neuroendocrine tumor can have significant clinical implications and impact patient outcome. Liver metastasis can cause various symptoms and complications, include abdominal pain, hepatomegaly, jaundice, and hormone-related symptoms such as flushing and diarrhea in functional neuroendocrine tumor, and impaired liver function. The presence of liver metastasis is an important determination of tumor stage, and can influence prognosis and tumor decision. In neuroendocrine tumor, the presence of liver metastasis is associated with higher risk of disease progression and poor overall survival compared to patients without liver involvement. The management of liver metastasis in neuroendocrine tumor is aimed at achieving local tumor control, symptoms relief, and improving overall survival. Treatment decisions are influenced by factors such as tumor characteristics, presence of metastasis, patient general health, and symptoms. When it comes to the treatment of liver metastasis, several modalities can be employed depending on the specific characteristic of the metastatic tumor and the patient overall health. Here is an overview of the treatment modalities commonly used for liver metastasis: surgical resection, liver-directed local regional therapies, systemic therapies, and combination therapies. In selected cases where the liver metastasis is localized and can be completely removed, surgical resection can be considered. This involves the removing of the tumor along with a margin of a healthy liver tissue. Surgical resection is typically preferred for patients with limited liver involvement and good liver function. Liver-directed therapies such as transarterial embolization, transarterial chemoembolization, radioembolization, and radiofrequency ablation or microwave ablation can be employed to target liver lesions and reduce tumor burden. Systemic therapies such as targeted therapies and chemotherapy can be used to treat liver metastasis when the tumor can't be surgically removed or targeted locally. Targeted therapies are drugs that specifically target molecules or pathways involved in the tumor growth and survival. Chemotherapy uses drugs that circulate throughout the body to kill cancer cells. The choice of systemic therapies depends on the primary tumor type, biomarker, and individual patient factors. Combination therapies: in some cases, a combination of different modalities may be employed to achieve optimal results. This can be involved a combination of surgical resection, local therapies such as RFA or TACE, and systemic therapies. It is important to note that the choice of the treatment modality depends on various factors, including the primary tumor type, extent and location of liver metastasis, patient overall health, and individual treatment goals. A multidisciplinary team, including surgeon, medical oncologist, and interventional radiology and other specialists, will assess the specific situation and determine the most appropriate treatment approach for each patient. Interventional radiology play a crucial role in the management of neuroendocrine tumor by offering a minimally invasive image-guided procedure that can be both diagnostic and therapeutic. Here are some key rules of interventional radiology in neuroendocrine tumor management. Interventional radiologists can use various imaging techniques such as computed tomography, ultrasound to precisely locate the neuroendocrine tumor and guide the biopsy procedure. A biopsy allows for histological confirmation of the tumor and the assessment of its grade, which helps in determining the appropriate treatment approach. Liver-directed therapy involves blocking the blood supply to the tumor or delivering chemotherapy or radiation directly to the tumor in the liver, thereby reducing tumor burden and improving local control. Radiofrequency ablation can be performed to destroy small liver metastasis or primary neuroendocrine tumor. Radiofrequency ablation uses heat generated by radiofrequency waves to ablate the tumor cells. It is a minimally invasive technique that can be performed percutaneously using image guidance, such as CT or ultrasound, to precisely target the tumor. Palliative treatment. Interventional radiology also play a role in providing palliative care for neuroendocrinal tumor patient. For example, in cases where neuroendocrinal tumor cause significant symptoms or complications, such as pain, obstruction, or bleeding, interventional radiologists can perform procedures to alleviate these symptoms. This may include interventions like stent placement to relieve obstruction, embolization to control bleeding, or nerve block for pain management. Transarterial embolization is a minimally invasive procedure commonly used in the management of neuroendocrinal tumor in the liver. It involves the selective blocking of blood supply supplying the tumor, leading to reduced blood flow and tumor death. Here is an overview of the principal mechanism of action, type of embolic agent, patient selection criteria, procedure steps, and outcome of transarterial embolization in neuroendocrinal tumors. The principle of transarterial embolization is to target the tumor by occluding the blood vessel that supply it. By blocking the blood flow, transarterial embolization deprives the tumor of oxygen and the nutrient, resulting in tumor necrosis. The procedure can be performed using various embolic agents, which are injected into the blood vessels feeding the tumor. Several types of embolic agents can be used in transarterial embolization in neuroendocrinal tumors. These include small particles such as polyvinyl alcohol and microspheres. These particles create a physical barrier within the blood vessels, leading to vessel occlusion and tumor ischemia. Drug-eluting beads are microspheres that can be loaded with chemotherapy drugs such as doxorubicin. They provide both embolic and local chemotherapy effect. Patient selection for transarterial embolization depends on several factors, including liver-dominant disease. Transarterial embolization is typically suitable for patients with liver-dominant disease, where the majority of the tumor burden in the liver, or non-resectable tumor. Transarterial embolization is considered when surgical resection is not feasible or appropriate due to tumor size or location or patient-related factors. Patient selection for transarterial embolization depends on several factors, including adequate liver function. Patient should be sufficient liver function to tolerate the procedure and the potential ischemic effect on the liver. Performance status of the patient should have an acceptable performance status to undergo the procedure. Embolization procedure. Subselective catheterization of the right or left hepatic artery is performed using an angled 5 French caster and a 3 French microcaster coaxially through the 5 French angled caster for super-selection catheterization of the feeding artery of the targeted tumor. Embolization is performed under fluoroscopy. Various particle material have been used, including BVA or microspheres. For chemoembolization and emulsion of cytotoxic drugs such as irinotecan, doxorubicin, mitomycin, or cytocisplatinum, or a combination of these. This embolization procedure is performed until near complete stasis of flow. Usually the liver loop with the bulk of the disease is embolized first. Antiemetic and adequate analgesia should be provided and preoperative intravenous hydration is important. Antibiotics should be administered for at least 72 hours to prevent abscess formation. Individual embolization are spaced 4 weeks apart, and most patients complete their embolization in 2 or 3 stages. Follow-up imaging studies are typically performed 1 or 2 months after the last embolization. Minor complications are common, such as transient nausea, vomiting, abdominal pain, and fever. Elevated liver function are also seen, peak usually within 2 or 3 days. Acute hypertension is occasionally observed in patients with carcinoid syndrome during or immediately after the embolization procedure. Most side effects resolve within 1 week. Outcome of transarterial embolization in neuroendocrinal tumor vary depending on factors such as tumor characteristic, patient selection, and the extent of liver involvement. Transarterial embolization can provide local tumor control, reduce symptoms, and improve overall survival in patients with liver-dominant neuroendocrinal tumor. However, individual response can vary, and the procedure may need to be repeated or combined with other treatment modalities. Hepatic arterial embolization has been shown to provide symptomatic relief in about 59 to 100% of cases. Symptomatic response occur as a result of reduction of the hepatic tumor burden and decrease of the hormone output in functional tumor. Objective tumor response have been noted in 33% to 80% of patients. This is a heterogeneous rate caused by variation in the tumor, in the type of tumor, and the choice of cytotoxic agent. The extent of liver involvement has been proposed to predictive of the tumor response. Radioembolization using yttrium-90 as a source of beta energy is currently approved for the treatment of hepatocellular carcinoma and colorectal cancer. Yttrium-90 is a pure beta emitter that decays over about a half-life of about 64 hours. Percutaneous palliative technique, radiofrequency ablation, cryoablation, and percutaneous alcohol injection. Patients with limited liver numbers and of unresectable liver mets may benefit from percutaneous ablative technique depending on the number and location of the hepatic metastasis. RFA can be performed under local anesthesia with sedation or under general anesthesia using ultrasound or CT guidance, and RFA needle probe is inserted into the liver metastasis. The position of the probe is confirmed by on multiplanar image to provide true centricity of the probe. And then generate a thermal ablation zone including tumor and margin. Anatomical proximity to the blood vessels can act as a heat sink. Once adequate heating is achieved for a specific duration based on the size of the ablation zone, the needle is withdrawn. Similar procedures are repeated for other lesions. Complete or significant symptoms relief has been shown in about 69 to 80% of patients treated with RFA, and the local control was achieved in about 74% of the symptomatic patients. Complications associated with RFA are usually restricted to those at the site of the needle entry, such as pneumothorax, neuritis, in addition to liver abscess. Cryoablation involves freezing of the tumor resulting in tumor ablation. Drawback includes the large size of the probe, which causes increased risk of the hemorrhage with higher rates of complication for larger mets. More recently, smaller gauge cryoprobes for percutaneous ablation, which allow placement of multiple probes, have been introduced simply. Imaging guidance is improved with the use of CT, which clearly delineates the ice pole for accurate visualization of the zone of treatment. Limited data remain for cryoablation treatment of neuroendocrine liver mets, but it has potential and requires further investigation by interventional radiologists. Laser thermotherapy. The advantage of laser application system is that it can be performed under MR guidance. This is of great value because the efficacy of the therapy can be evaluated simultaneously using MRI. Case 1, transarterial chemoembolization in liver metastasis. A 55-year-old male with a history of well-differentiated neuroendocrine tumor of the pancreas representing with multiple bilobar liver metastasis. The patient underwent 2 sessions of TACE, during which selective catheterization of the hepatic artery and infused a chemotherapeutic agent, irinotecan, mixed with embolic particles, hepasphere, into the tumor feeding vessels. This results in targeted chemotherapy delivery and tumor vessels occlusion. Follow-up imaging shows a significant reduction in the size and number of the liver metastases. The patient experienced symptoms improvement and has a prolonged period of disease control. Case 2, radiofrequency ablation for liver metastasis. Patient profile, a 62-year-old female with a history of small bowel. Conclusion. Interventional radiologists play a crucial role in the management of liver metastasis from neuroendocrine tumor through minimally invasive procedures such as transarterial chemoembolization, radiofrequency ablation, and selective internal radiation therapy. Interventional radiologists can deliver targeted treatment directly to the tumor site while minimizing damage to the healthy tissue. This intervention have demonstrated significant clinical benefits, including tumor size reduction, symptoms improvement, and prolonged disease control. The incorporation of interventional radiology into routine clinical practice has revolutionized the management of liver metastasis from neuroendocrine tumor. This minimally invasive technique offers viable alternative to surgery, providing patients with this invasive treatment option, shorter recovery times, and improved quality of life. Furthermore, ongoing research, continuous learning, and multidisciplinary collaboration are essential for further enhancement treatment outcome and advancing the field of interventional radiology in neuroendocrine tumor management. Thank you.
شكرا دكتور احمد. هي عندي كومنت صغير بس، او يعني 2 كومنتس. اول حاجه ان فعلا النيورو اندوكراين تيومرز من الحاجات اللي اندر يوتيلايزد فيها رول اوف انترفنشن راديولوجي، يعني وان فيها كاركترستيك مهمه جدا ان هي بتبقى enhancing في السي تي زي الهيباتوسيل كارسينوما، ف sometimes mistaken as هيباتوسيل كارسينوما في الدايجنوز يعني. والانهانسمنت ده اللي بيخليها فعلا very يعني جود ريسبونس للكيمو امبولايزيشن والترانس ارتيريال ثيرابيز بالذات يعني. شكرا دكتور.
شكرا دكتور سعفان.
اكشولي انا ليا
سعفان.
سمول كومنت. لا خلاص، ما هو
ماشي.
بالنسبه للدكتور سعفان انا
شكراً
كومنت
يا فندم.
از هيباتولوجيست بالنسبه بما ان الدكتور سعفان اتكلم عن الامبولايزيشن سندروم، بوست امبولايزيشن سندروم والانتي بايوتيك ريجيمن. هو في الحقيقه احنا بالنسبه لنا البيشنت بيبقى برايمد باي انتي بايوتيك زي اي سيرجري اتليست 1 اور بيفور ذا بروسيجر، والبيشنت يعني should be searched for any infection. يعني لازم بنعمل للبيشنت سي بي سي وسي ار بي ويبقى completely examined. لو في اي infection should be completely eradicated قبل ما اعمل كيمو امبلايزيشن، وده بيبقى وايد بالكلينيكال كونديشن بتاعته والارجنسي فور ذا بروسيجر. واكشولي لما بندي انتي بايوتيك بوست مش 72 بندي 5. احنا هنا في مصر مش اقل من 5. الله يكرمك. اتفضل.
دكتور محمد، بس لو اسال سعادتك، هو احنا كده يعني بالنسبه للميتس اللي في نيورو اندوكراين هو نفس النتيجه او نفس البروتوكول او نفس التكنيك هو بتاع الميتس العادي، بس الاوت كام افضل، صح كده؟
هو يعني نيورو اندوكراين انا اللي اعرفه يعني عنها انها بتيجي بفاريبل كورسز وكده. الحقيقه اللي معاها ليفر ميتاسيس اللوكال ثيرابي بتاع الليفر فيري افيشنت، ان هي من الكاركترستيك فيها انها بتاخد الارتيريال ابتيك ده زي الاتش سي سي. مش عايز اقول لك ان ربما احنا بنعمل حد اتش سي، عندنا اتش سي وكانت اصلا نيورو اندوكراين تيومرز، انها ميس دايجنوزد في حالات كتير قوي قوي قوي. يعني هي اندر دايجنوزد عموما، وفي مصر بالذات عشان البروبلم بتاع البايتات سي والاتش سي سي، فاحنا حاجات كتير قوي ربما بتبقى دايجنوزد عنها اتش سي وهي اصلا نيورو اندوكراين تيومرز. وده هي بنشوفه كتير، يعني ساعات تشوف ليجنز وهي مكتوبه في الايمجنج اتش سي، لكن بنقعد في الام دي تي لا دي مش اتش سي، هناخد بايوبسي وفعلا تطلع نيورو اندوكراين تيومر. فهي يعني كيمو امبولايزيشن اندر يوتيلايزد فيها، واحنا في برضه اوفر دايجنوزس فيها، فاحنا محتاجين نبص اكتر في الام دي تيز لموضوع النيورو اندوكراين تيومرز انها فعلا كومن، وعلاجها فعلا يعني عاده اللي انا يعني ساندوستاتين والعيان بيقعد ياخد الحاجات دي ويبقى ريزيستنت وكده. طيب ليه ما بنفكرش في اللوكال ثيرابي في الليفر؟ برضو ده مهم جدا يعني.
شكرا دكتور محمد.
I think يا دكتور احمد كمان ان احنا عشان ما بناخدش باوبسيس في بعض حالات الاتش اس سي بنعتمد مثلا على الالفا فيتوبروتين
صح
والليفر. واي ثينك برضه زي ما حضرتك تفضلت ان الفيفوربل بروجنوزس بيبقى شويه احسن طبعا من الاندوكراين لما يحصل لهم كيمو امبلايزيشن which is future
صح
ان شاء الله باذن الله. Here introduced my dear Professor Dr. Ahmed Abdelhadi and his session about pancreatic cancer history and updates in treatment. تفضل دكتور أحمد.
Good morning, dear colleagues and professors, dear chairman. Thanks, Professor Reem, for this kind invitation for me to be here with you today. My talk today, I was trying to make a conclusion or a sum up of the cornerstone studies that changes our management in treatment of pancreatic cancer. A glance at the unique biological characters of the pancreatic cancer, we have the mortality of the pancreatic cancer is very high, although it's not a very common disease in worldwide. And we see that in red line, we see that almost 80% of the pancreatic cancers have high mortality rates. Patients with pancreatic cancer have a poor prognosis. Less than 12-month median overall survival, and 2 to 6 months median overall survival to metastatic pancreatic cancer, 11% median 5 years survival, and 80% have advanced disease at diagnosis. Unlike other cancers, there have been almost no improvement in pancreatic cancer survival rates, and we see that in the green line, it is the bottom of the chart, the pancreatic cancer survival rates are very low in comparison to other cancers. And there is a high expectation that pancreatic cancer rates will increase in the next 20 years from 70%, and the mortality rates will increase by 70%. The pancreatic cancer is anticipated to become the second leading cause in cancer-related deaths by 2030. And all along the last decade, we have almost 20 studies that have failed to improve survival or gain response, while only we have a few successful studies that may change our view in treatment of pancreatic cancer. Why this problem to pancreatic cancer evolved? Because the tumor biology have insufficient drug delivery and inadequate drug exposure because of the dense stromal layer, immunosuppressive tumor macrophages, and low microvascular density and leaky vasculature. Management of pancreatic cancer. For the adjuvant pancreatic cancers, adjuvant treatment, we have the first keynote study, our cornerstone study, the CONCO-1 randomized study, giving the adjuvant chemotherapy after resected tumors, gemcitabine, and long-term outcomes. They enrolled almost 360 patients, half of them randomized to receive adjuvant gemcitabine versus observation only, and it was the first study that gave an adjuvant treatment for pancreas. And we see here that the median disease-free survival was almost 13 months in the gemcitabine group compared to only 6 months in the observation group, and the overall survival, impact in the overall survival was quite minimal, but in the response it was very marvelous. And we see that in the subgroup analysis that the higher stages comes to, the lower stages, T1 and T2, has a better prognosis. And if there are some cases with R1 resection, it will benefit more from the adding gemcitabine as an adjuvant if you have a positive margin. At the same time, the overall survival is affected by the negativity of the nodal status and the early tumor stages. The next study, the adjuvant chemotherapy, fluorouracil plus fulinic acid versus gemcitabine. They are trying to give in SBAC3, trying to compare between giving an adjuvant gemcitabine versus giving fluorouracil after surgery. And they recruited almost 1,100 patients, and half of them for 5-fluorouracil and the other for the gemcitabine. And we see that in both curves there is no significance between both types. So we are having the next step, which are the toxicities of the 5-fluorouracil and adjuvant or gemcitabine. We see that most of the side effects coming to the gemcitabine in the form of neutropenia and thrombocytopenia, while the GI symptoms for the 5-fluorouracil. So we have to select our cases to give them either gemcitabine or 5-fluorouracil according to their condition. And giving now the recent study for Folinox or gemcitabine as an adjuvant therapy for pancreatic cancer. This study recruited almost 500 patients. Half of them was assigned to give modified Folinox versus gemcitabine as an adjuvant. And according to the performance status of the patient, we have good disease-free survival, beneficial or marginal benefit for the modified FOLFIRINOX. Good performance status showed dramatic improvement in both progression-free survival and median overall survival in favor of receiving FOLFIRINOX, and in eligibility criteria for this trial, limiting real-world generability because the side effects gained from giving this combo. And in subgroup analysis of these cases, we see that the most benefited group was the stage 3 and stage 4 disease, and the most benefited diseases was The most benefited patient, the stage 4 and stage 3, in favor of giving modified FOLFIRINOX, is especially if the patients are getting have a good performance status. The toxicity of FOLFIRINOX can be managed with a variety of approaches, and we have the group from Memorial Sloan Kettering Cancer reported good activity and acceptable toxicity of the first line FOLFIRINOX at 80% dose intensity, and the median overall survival was 12.5 months in the metastatic setting and 13.7 months in patients with locally advanced disease. Comparison of adjuvant gemcitabine with gemcitabine with capecitabine monotherapy in patients with resected pancreatic cancer. This was SPEC4. It is a randomized trial, recruited almost 700 patients. Half of them received gemcitabine only, and the other half received for gemcitabine plus capecitabine. And we see here that in the general overall survival, there is more, a benefit was very, very little, 25 month median survival for gemcitabine arm, and 28% in the gemcitabine plus capecitabine arm. If we have a deeper look in the patient's criteria, we see that the most benefited patients who has a negative margin after resection. So we see in the orange arm, the orange line here, the orange line, I can see the laser, the upper orange line, the gemcitabine plus capecitabine will have a better survival if they have a negative margin, and followed by gemcitabine single agent in the next blue line, they have a better survival if they have also a negative margin. So the message from here is better surgery give us a better overall survival. Another trial giving fluorouracil versus gemcitabine, comparing fluorouracil versus gemcitabine chemotherapy before and after fluorouracil-based chemoradiation following resection of pancreatic adenocarcinoma. We have this after giving the chemoradiation, all patients had a chemoradiation and we receive adjuvant fluorouracil versus adjuvant gemcitabine. And here is also, there is no significant benefit from both, giving both either gemcitabine or 5-fluorouracil following the chemoradiation, with a slight benefit for the 5-fluorouracil. And we see in other reported cases from multiple trials, either ESPEC or CONCO or RTOG, following the fluorouracil, giving fluorouracil following the chemoradiation or gemcitabine, we see that the 3-year survival and 5-year survival rates are better with the arms containing gemcitabine. In first-line treatment of cancers, in metastatic cases, we have the IMPACT trial, increase the survival with using nab-paclitaxel plus gemcitabine. These the patient, almost 900 cases, randomized have to have nab-paclitaxel plus gemcitabine in one arm, and the other arm giving gemcitabine alone. And we see in the survival curves that the nab-paclitaxel in these metastatic cases and at locally advanced cases, nab-paclitaxel plus gemcitabine giving a better survival benefit in the progression-free survival and overall survival. And the same, the most beneficial in subgroup analysis, the most beneficial was the number, have a less number of metastases, and the also the liver condition. If there is liver metastasis, will be benefited more. The NAB liposomal irinotecan in Napoli-1 with fluorouracil and fluoronic acid in metastatic pancreatic cancer cases, especially after they receive gemcitabine chemotherapy based. In Napoli-1, they randomized 3 arms. The first arm is liposomal irinotecan plus 5-fluorouracil and calcium folate. Second arm is calcium folate with 5-fluorouracil without liposomal irinotecan. The third arm is liposomal irinotecan single agent. And we see that in the nab-paclitaxel, in the nano-liposomal irinotecan with fluorouracil in the red arm have a better overall survival, especially at the first 3 months. We can see the separation of the curves at 3 months. And at the same time, the progression-free survival is begin from the 3rd month also with statistically significant data. The same here, we can see that the benefit from treatment with this protocol will benefit also from the larger tumor volume and the better liver function. In NABULI 3, we can give the NALFIRINOX versus nab-paclitaxel and gemcitabine in treatment-naive patient with metastatic pancreatic ductal carcinoma, because we want to give the patient more chance to not to be heavily pre-treated before starting this protocol. We have assigned 380 patients versus 387 patients. NALFIRINOX versus nab-paclitaxel gemcitabine, and we see that the combo NALFIRINOX gives a better overall survival and a better progression-free survival for these cases. And now we can see in the NCCN guidelines the new adjuvant in resectable and borderline resectable cases. We can give the FOLFIRINOX and the modified FOLFIRINOX or gemcitabine plus nab-paclitaxel. And in the adjuvant setting, according to the SPEC and CONCO, we can give the modified FOLFIRINOX and gemcitabine capecitabine as a category 1. And in locally advanced disease, we can see in NCCN guidelines, they are following the performance status in selection criteria for treatment of these cases, either performance status 0-1 or intermediate or poor performance. The take-home message: we have a pancreatic cancer, is a very complicated disease. Tailoring the treatment according to the patient's initial staging and general condition is the cornerstone in the management, and don't miss the borderline resectable pancreatic cancer, as more of the RC resection, the longer the survival and the longer the local control. The various phase 3 studies won't be confusing, but give you the chance for allocating your patient in the right way according to this disease behavior. Thank you.
Thank you, dear Professor. Any question? Okay, thank you, dear Professor, for your nice talk. And now we are shifting to the next speaker, the elegant Professor Iman Dibawi. She will talk about the Egyptian experience in the 57 hospital about SBRT in upper GI tumor.
First of all, I want to thank the scientific committee for inviting me to attend this comprehensive, valuable conference, with a special thanks to Dr. Reem Iman. Also, I want to thank my team who is sharing me in the multidisciplinary clinic for treatment of upper GI tumors. Dr. Walid Abdelati, Dr. Iman Barakat, Dr. Mohammed Gharib, and Dr. Reem Iman. And also I want to thank the audience. Today I am going to talk about stereotactic body radiotherapy, SBRT, and also we call it stereotactic ablative radiotherapy, SABR, for the management of upper GI tumors and our experience. SBRT is a very interesting and new topic in radiation area. Most of the people are not familiar with it. So I am going to talk about some background technical problems that we face in SBRT and how to solve these problems and some of our cases. When we talk about SBRT, we are talking about very, very precise delivery. We are talking about very high dose per fraction, talking about ablative dose, which is ablative to the tumor and also ablative to the critical surrounding structure. So it should be very, very conformal. Since each treatment is very potent, so we are not need many of the treatment. We typically treat with from 1 to 5 treatment. In SBRT, there is a very high dose per fraction, so there is some mechanism which have been seen in SBRT, not seen in conventional fractionation, which is damage to the endothelial cells supplying the tumor, also immune phenomena, and also what is called abscopal effect. Since we see that the systemic disease outside the radiotherapy fields has a response, although it's outside the radiotherapy field, and this is a very interesting area in research. We are facing some technical problems in stereotactic body radiotherapy for treating upper GI tumors, target and critical organ definition, tumor and organ motions, how to spare normal tissue, and how to have a precise setup and treatment delivery. In terms of the first one, target and critical organ definition, IGRT or image-guided radiotherapy is very crucial for target delineation. This is an example of HCC patients. This is a triphasic CT. If you have a look for the hepatic arterial phase and the hepatic portovenous phase for these patients, you appreciate the small tumors in You appreciate the small tumors here in the portal vein, but of note, you have to have a look for the delayed phase for these patients to appreciate a very, very extensive tumor. So if you depend or rely on the regular CT with contrast like we use in conventional fractionation, you will contour a very, very small tumor and you will miss most of the tumor. So triphasic CT is very, very crucial in SBRT for HCC or pancreatic cancer. Regarding the critical organ definition, again, image-guided radiotherapy is very important, and this is an example of one of our case. And as you see, this is the tumor, and there are many exclusive sensitive critical structures in the abdomen, especially the duodenum and bowel. So we have to delineate these organs very carefully. And again, we are not familiar with contouring these critical structures, especially the duodenum or the bile duct, but there are some guidelines for how to contour these structures. So we have to be guided with this, and also we have to be guided with anatomical atlas. The second problem is the tumor and organ motion, and this is the most obvious technical problem. Tumor and organ motion can be managed by many techniques: abdominal compression, ABC or active breathing coordinator, gating technique by using fiducials, 4D CT and MRI limit. In terms of abdominal compression, this is an example of one of our cases treated with abdominal compression. Abdominal compression is a very, very simple technique to deal with organ motion. We emphasize on the patient comfort rather than doing things like extensive compression, because the patients will not tolerate, because the treatment will take several minutes. So we try to shift the breathing from the diaphragmatic breathing to the chest breathing and stop or reduce the movement of the diaphragm, which is gonna drive the liver up and down and from side to side during breathing. So this is why we are using mild compression in the abdomen. Also, we use the ABC device, the active breathing coordinator. This is also a non-invasive advanced technique to deal with organ motion. It helps the patient to hold the breathing temporarily and in a consistent way. This is again example of one of our patients treated with ABC. ABC consists of snorkel, nasal clip, and also a special goggle to allow the patient to see the computer while he is lying on the table, and the green button. We teach the patient how to use the APC device as the patients will take a deep breath and hold his breathing. And when he presses on the green button, the computer will be activated and the radiation will be on. And again, if the patients breathe regularly, the computer will be deactivated and the radiation will be off. Again, this is very nice, but a little bit complicated, and sometimes some of our patients cannot learn how to use the APC, so we'll go for abdominal compression. Also, we have the CyberKnife in our institute. We have a real-time tumor tracking as the CyberKnife combines the respiratory synchronous tracking together with fiducial marker tracking, and also the BTV will be so small, almost from 1 to 2 millimeter. So also we will spare most of the normal liver. The other technical problem also in SBRT, how to spare the normal tissue. In HCC typical SBRT plan, the tumor dose often limited by normal tissue tolerance, like the volume of the normal liver irradiated and the proximity to the luminal GI organs. This is on the left side. This is an example of one of our patients. The target is covered by 40 gray, because our goal usually starts with 50 gray in 5 fractions based on RTOG 1112. But in these patients, we were not able to deliver 50 gray, so we deliver 40 gray, because as you see, the tumor is very near to the bowels and also the duodenum. On the right side also, this is another patient. As you see, the tumor, the target and the tumor in blue color is very near to the gallbladder. So also we deliver 35 gray in blue color to the target because the tumor was very near to the gallbladder. The last problem is how to have precise setup and treatment delivery. Usually we use a full body vacuum bag for proper embolization, and this is an example of one of our patients treated with this vacuum bag for proper embolization. Also, during treatment for precise setup, we have a COM-beam CT image-guided radiotherapy, and this is an example of one of our patients. This is also the checker-boarded images for the patients. One set of the images are related to the triphasic CT done on CT-SEM, and the other set is for COM-beam CT. And this is one of my favorite patients, because this patient treated before radiation by TASE. In TASE, they inject Lipitor, which stay on the tumor for several weeks after treatment. So it lights up during triphasic CT and COM-beam CT, and we can use like a fiducial. Regarding the treatment schedule, we are treat the patients by using the RTOG 1112, following the RTOG 1112 dose regimen. Usually our goal to start with 50 gray in 5 fractions, but depending on the mean liver dose, and the dose to the critical structures, we can reduce the dose to gradually to the minimum for 27.5. And as I illustrated before, that one patient we were not able to deliver 50, and we we delivered 40 instead. And also the other patient we delivered 35, although our initial goal was 50 grams. This is the AAPM task group 101, which published in August 2010. And if you are treating upper GI tumors with SBRT, for sure you are familiar with the AAPM task group. It shows us those constraints for all critical structures for single, 3, and 5 fractions. Regarding the case examples, this is 63-year-old male, had hepatitis C positive, diagnosed 20 years ago, received treatment, and now he is BCR negative. Diagnosed with HCC in August 2022, treated with TACE 3 times with residual lesion 8.1 by 7.4 centimeter in segment 4, along with porta-hepatis lymph node 5.4 by 3.3 centimeter, child BOA5 liver function, treated with SBRT 40 gray in 5 fractions, ended in May 2023. And he responded nicely to SBRT radiological and clinical. This is his triphasic CT, the baseline 1 month after SBRT and 3 months after SBRT. And Dr. Gharib will comment on this triphasic CT.
لو هنلاحظ بس في البيز لاين الاولاني في الليجن وفي الليمف نود اللي هي الانهانسنج ليمف نود اللي في الايمج اللي على اليمين خالص. بعدها بشهر كان واحنا ادينا من ادينا الاس بي ار تي ادينا على الليجن وعلى الليمف نود، وكان الليمف نود دي هي المين ايشو عندنا، بالاضافه للسيستميك ثيرابي اللي كان خده يعني. فحصل بعد شهر عملنا بعد 1 مانث، دي كانت من الفيرست اكسبيرينس في الكيسز. فبعد 1 مانث كان لا لسه كان دينا لسه ايرلي وما كانش بان الفول ريسبونس بتاع التيس بتاع الاس بي ار تي، لكن الحقيقه بعد شهر ونص او 3 شهرين حصل significant decrease في السايز بتاع الانهانسنج ليجن اللي هو البريفيوسلي تيست ليجن، significant decrease في الانهانسمنت، وفي نفس الوقت حصل يعني تقريبا برضو الليمف نود الانهانس بتاعها اختفى خالص، وبالراديولوجيكال الترا ساوند ما لناش عارفين ندistinguish it good يعني. فحصل يعني radiologically it was very fine و successful يعني.
This is another example. This is 79-year-old female diagnosed with adenocarcinoma of head and proximal body of pancreas, encasing celiac trunk as well as portal vein 4 by 3.1 centimeter. She was unfit for surgery or chemotherapy, treated with SBRT 30 gray in 5 fractions, ended in July 2023. And again, she responded nicely to SBRT radiologically and clinically. And this is her MRI on the baseline and 2 months post SBRT. And again, Dr. Gharib will comment on it.
الايمج اللي فوق الام ار اي نلاحظ يعني حاولت اجيب نفس الفيو بتاع الليجنز. كانت الليجن حوالي 3.5 سم او اكتر. الحقيقه حصل significant decrease في السايز يعني compared الابر لللور ايمجز يعني. الحقيقه بقت يعني تقريبا انت في الام ار اي حتى الاوبينيون بتاع التقرير بتاع الام ار اي لا كانت يعني significant decrease في السايز، غير بقى clinical improvement بتاعت العيان اللي حصلت significantly ناحيه البين والابيتايت وكده يعني.
هو اكيد طبعا مش هعرض عليكم غير الحالات اللي هي استجابت كويس يعني، مش هضحك عليكم يعني. اوكي ثانك يو.
Last our speaker Professor Dr. Walid Abdelati, Professor of Hepatology and Tropical Medicine Ain Shams University. دكتور وليد يعني الحقيقه يعني غير ان هو يعني اخ واستاذ وزميل عزيز، يعني هو كان يمكن من الانيشيتورز بتاعه ان احنا نعمل ام دي تي وننكلود الاس بي ار تي في المانجمنت اوف الجي اي تي تيومرز، الليفر اند بانكرياتيك تيومرز الحقيقه. وهو من الناس يعني اللي سبورتنج جدا للموضوع، وهو اللي جمعنا وجابنا من عين شمس، وقابل الدكتوره ريم والدكتوره ايمان، وزي ما تقولوا لم الشام مع المغربي، وجاب عين شمس مع ال 57 مع الدكتوره ريم في معهد السلام. يعني الحقيقه يعني وراجل يعني effortless، يعني ما بيطلش اي مجهود في الموضوع ده. He will talk about the role of SBRT in HCC beyond palliation.
شكرا اخي العزيز دكتور محمد على الانترودكشن. I would like to thank Dr. Reem and the organizing committee for this wonderful gathering and this wonderful session, really. As Dr. Muhammad was telling us that we are planning for SBRT before, when I had a patient 10 years ago, when he came me, he was 35 years old, gentleman, and his wife coming to my clinic and said to me, everyone saying that my husband is dying, you have to do something for him. And unfortunately, he was having a HCC 8 centimeter with portal vein thrombosis. And I asked Dr. Muhammad Gharib, if you remember, how can we help this gentleman? And unfortunately, we couldn't do anything. That was, I think, even before Nexavar. And Nexavar was a little bit difficult for such patient before Ministry of Health support. So I began to think about something to what shall I do for such patient, and I was feeling pity for him, but I really don't know what to do. So I went to Germany for what we call brachytherapy, which is it's your type of work. So I'm going ان انا ابيع الميه في حق الحرثيين فهتبقى صعبه شويه, but I really wanted to help this patient. What shall I do? So I went to Professor Reike, which was interventional radiology, to what he did, put iridium in HCC, and this iridium decay for months, and he put multiple roads by what you can say punctional type, and I found it's very difficult for us to do that, especially doing with iridium type. I tried to have this technique and came back home and to do it, but unfortunately with my oncology friend and one of the surgeons in Liver Institute, but we couldn't. So I searched for something else. That's why we began this thinking of SBRT. How can we help? And one of my friends in Gamma Knife asked me that there will be a body type of radiation, and I think it will help you first of all by mattress, and then after that by abdominal compression, and then after that by APC. And then we have this gathering in two places, one in Air Force Hospital and second in 57 Hospital. And I was honored to have a connection with Dr. Ali Hosni from Canada, asking him to help us about the first presentation in SBRT, and he's kindly helped us for that. And he was guiding us how to do SBRT in certain population. And I'm happy to have him today and to see him again after 1 year. And I think he will be happy with this new cyberknife. Thank him very much for his support. So, what about our objective today? It's research and guidelines, our MDT case presentation, and I will be, of course, Dr. Reem was asking me to finish early, so I will try to minimize my talk. That was first presentation to us as a group, how to help support advanced thrombosis. Again, for such patient who is 10 years or 12 years ago with portal vein thrombosis. So I asked Dr. Muhammad Gharib, what shall I take for patient? Because you know the interventional radiology now, Dr. Muhammad Gharib or Dr. Ali Saeed, they are always like to have our patient from HCC, except portal vein thrombosis. So I took this type of dilemma and we asked for movement. How can we help each other for that? So as a friends, we could not, as Dr. Ali said before, we will not compete with each other. We want to do a beautiful work. So again, we ask for type of portal vein thrombosis, which is for test not possible. So that was our main. And after our fight with our radiation oncology, can we do repeated SBRT or not? So we have this to be answered. Yes, we can do that. And again, as Dr. Ali was telling us also about sorafenib and head-to-head with SBRT, of course, SBRT showed a little bit much better than sorafenib, or combination will be much better. It's always combination which is possible. So what about sometimes in Air Force Hospital, we have a liver transplant surgeon, and he always having a big problem with such patient with portal vein to having a bridging to transplant. And this is a new idea, and that's why this SBRT now get into BSLEC, and we are happy really to help both surgeon and interventional radiology to downgrading, and that was our help, to downgrade our patient from palliative to curative, sometimes for liver transplant, or from curative to palliative, yes, but with big survival time from 6 months to 2 years and more even. We have patients with 5 years, as Dr. Iman Barakat was having in the hematoma group, they have 5 to 7 years survival, sometimes 10 years, which is for us, it's astonishing. So our MDT was having to think what's supposed to be our MDT, the main core: interventional radiology, hepatology, oncology, and hepatobiliary surgeons. Role of interventional radiology: primary evaluation of the patient, then decide the need of treatment with TACE or IRF or whatever modality is sometimes there even, and led to the target delineation with the oncology, follow-up patient radiology to evaluate response and recurrence, which sometimes is very important to predict or to see the recurrence as soon as it happens, to have a very good prognosis and overall survival. Role of hepatology for us: primary evaluation of liver function and of course Charles class, evaluate eligibility criteria, decide for proper medical treatment, clinical follow-up, endoscopy of course, and detect toxicity for the SBRT or whatever the problem is going if you have combined SBRT with chemotherapy. A role of oncology: evaluate eligibility criteria, planning of treatment, of course, for target delineation with interventional radiology, follow up a patient to evaluate toxicity, clinical follow-up, and of course, chemotherapy also, and plan possible combination, even 2 or 3 type of modalities. Hepatobiliary surgeon, who is always will be the last one to decide sometimes, to evaluate resectability and to examine. Even we have a very nice lady, 85 years old, as Dr. Muhammad Gharib say Dr. Iman in Air Force MDT, 85 years old, and we were all very afraid to touch her. And she did a partial hepatectomy, and she is very good nowadays after surgery. And even as you see, everyone is happy because we cannot believe that 85 years old, and she is perfectly well after this operation. And that's the beauty of MDT, really. Our machine was Electa Versa HD, and of course simulation, as Dr. Iman was telling us about ABC, and it was very strange that we have all these machines. It was brand new and putting in what we can say, the shelf, and no one touched it, except when we search in 57 hospital or in Air Force. So sometimes we have the machine and we have something with it, but we never see what shall we do. What about inclusion criteria? Adult patient, of course, performance status. We performance status from 0 to 2, but sometimes we put 3. And shall boot certification A, B, and sometimes C. But sometimes C, it's very, even I was chatting with Dr. Ali before, can we have people with child C? It was not published, but we saw some patient with child C, and we have a very good response with them. So, but it needs again a decision of MDT. It's not single decision, it's MDT decision. And of course, failed of previous treatment, and that's what I'm saying to you. Sometimes we have the patient who's really doesn't have anyone to help. Portal vein thrombosis, life expectancy less more than 3 months, non-affected more than 3 months, non-affected liver and to be thread, and it must be more than 700 cc. Patient is alert, of course, and can cope with the dissemination. This is a child classification, and of course for non-hematologist like oncology, child A, it will be from 5 to 6 points. It's depending on flossy, ascites, bilirubin, and albumin, and there is sometimes modified even child B. Child B from 7 to 9, and child C is from 10 to 15. What about exclusion criteria? It's massive ascites, and suppose if you have an active HCC, will not and will not recommended that. Total serum bilirubin more than 3. Although we have some patient with C, child book C, more than 3 bilirubin C, but very good performance status. That's why we had this patient to be included. Performance more than 3, hemoglobin less than 9, platelet count less than 80, liver enzymes more than 6 times, and patient can be trained for, as Dr. Iman was saying, is not cooperative with such technique. Follow-up really by lab and from imaging, and so we always use after 6 weeks and even after 3 months. What about treatment? It's some case presentation. It's 53 years old gentleman, had successful test with local control, started to show rising tumor marker, triphasing, confirmed partial portal vein thrombosis, and not candidate for this, and that was our aim. And it's always, again, our aim to help. So it's an MDT decision. How can we help this patient? And this is an Air Force hospital, and we really did the whole subject, and I'm honored to have this from my dear friend, Dr. Muhammad Arib. That's significant declaration of portal thrombus, and sometimes I put this letter just in my jacket, because it was very happy to have the success, to feel that you can help your patient with something brand new, unique, and the patient is really very happy. Instead of saying we can do anything, now we can do something for you. I will be going that. So after all our experience, we did publication, first publication for us, and I think in our MDT for Egypt. It was in ESMO the last year about stereotactic radiotherapy for palliative management of HCC associated with portal vein. And my dear friend, Professor Dr. Khalid Abdelkarim, my very dear friend and dear brother, and who was accompanying me in Air Force Hospital. And really, this was in 16 years, and I think we have 16 patients. Yes, we have 16 patients, and we did that, and we see how much survival that our survival is much better than others when we have this SBRT with portal vein thrombosis. And this is the what you can say it's explanation for this. And because of the short of time, I will not say it. And after recolonization of portal vein, what's next? It will be our second publication, which will be, I honor to have it, will be published in the last, and will be AASLD, American Association of Study of Liver Disease. After 5 days, it will be poster presentation, and we have 28 patients in the same thinking that we have conclusion that palliative treatment of advanced HCC could lead to improved survival in patients with good performance status. Larger size multi-center should be taken to have our great success to help our patient. And thank you very much for your help. Thank you.
Thank you, Dr. Walid. Any questions from the floor, from the panel? طيب
شكرا لحضرتك جميعا على السيشن الجميل. ويعني اهم ما يميزه ان احنا يعني من غير ما ناخد بالنا كده او واخدين بالنا احنا لفينا مصر كلها تقريبا، كل الجامعات ما شاء الله. يعني بدانا القاهره ورجعنا لها في الاخر، حلينا بعين شمس ومعهد القومي و57 وعين حتى رحنا السلام واسوان الاثنين مع بعض، وفي كندا وفي منصوره وفي طنطا. طبعا الشرف ليا وجودهم معايا، فبشكركم حتى منصه كريمه على كافه التخصصات ما بين اشعه وتروبيكال وجراحه وانكولوجي. بشكر حضراتكم على السيشن الجميل ده، وشكرا ساينتفك كوميتي اللي حطوا التوزيعه الجميله دي. شكرا لحضراتكم. ننتقل بقى على السيمبوزيوم. شكرا لحضراتكم.